talk about alcohol use disorder and treatment with medications and nutrients. I just wanted to make you aware of the next two programs upcoming for the Alliance. We're going to have next month on the 24th, we're going to have someone from Bridging the Gaps talking about inpatient residential addiction treatment. And then on August 28th, we're going to have Dr. Shafana talk about your neurotransmitter testing. I know that's been controversial in our field, but so she's going to present and you can ask your questions. So let me give you a brief introduction to Dr. Umhau. I've known Dr. Umhau for some period of time. So he currently works in a private medical practice called Alcohol Recovery Medicine, which is devoted entirely to the treatment of alcohol use disorder. He worked for about 20 years at the National Institute on Alcohol Abuse and Alcoholism. There, he authored numerous papers related to alcohol use disorders, focusing on medication development and the effect of diet on brain inflammation and psychopathology. Dr. Umhau gives frequent lectures on the treatment of alcoholism and is considered a leader in his field. He's also a United States Public Health Service officer, where he served in the FDA Division of Psychiatric Products and was a medical director of the White River Indian Hospital. Dr. Umhau earned his bachelor's at Davidson College and an MD at Wake Forest University and an MPH at Johns Hopkins, and he's a certified physician executive. He completed a residency in clinical preventive medicine at Johns Hopkins and is board certified in both addiction medicine and preventive medicine. Dr. Umhau, did I introduce you correctly? Are there any?
Absolutely. I'm not a public health service officer anymore, so I retired. So
you're retired. Okay. All right.
So I'll go ahead and share my screen. I hope, can everybody see my screen here?
Yes, not yet. Yes, yes.
All right, so we're going to play this slideshow here. If I can do this correctly. All right, so we're looking at my talk, which is the alcohol use disorder treatment with medications and nutrition. I'm really excited to be able to give this to you. Thank you for asking me. I love sharing this information because I know that if I do a good job, you'll catch the excitement about helping people with this problem and lives will be saved. It's really the most satisfying thing I've ever heard of in medicine. I've done a lot of different things. So why do people get alcohol use disorder? Well, here's a typical patient. We'll talk about John. He's a 55-year-old married man, professional, and he's found as stress increases with his life, alcohol helps him cope. He drinks every evening, about 30 drinks a week, and really has no shut-off valve. He just keeps drinking. He says that in college, he could really hold his liquor, and he drank heavy in college, but he was able to do his work. By the way, if someone can hold their liquor and isn't affected by alcohol that much when they're young, that's a sure sign that they're highly likely to become alcohol addicted when they grow up. That's one of the reasons why people become addicted to alcohol is because they can't hold their liquor. And so that's a genetic predisposition to drinking. Like his dad, he could stop alcohol for a while, but he generally always returned to drinking. Now he's worried about his health. And he's recognized that he's going to lose some friends if he continues to drinking, and his wife's not happy with him. He tried counseling. He's been with a counselor for about 5 years who's been working to help him stop drinking. Been to Alcoholics Anonymous. He was active for a number of years. Also tried Smart Recovery, and they worked somewhat, but he always returned to drinking. Well, there's a number of reasons why people would continue to drink. Obviously there's social pressures, peer pressure, psychological traumas from childhood, anxiety, brain injury, head traumas that reduce someone's cognitive ability, as well as nutritional deficits, which I firmly believe are way more important than people realize. And we must realize that they're also iatrogenic or physician-caused reasons why people start drinking. Probably the most important one in my practice is the indiscriminate use of citalopram and other SSRIs, which in some people drastically increase the pleasure associated with drinking. But it's gradual, and very few psychiatrists that prescribe this recognize that after they've treated a depressed patient with antidepressants and they start drinking, the drinking increase is attributed to the depression, not to the SSRI. Maybe some of you have had patients with gastric surgery who have increased their consumption of alcohol as a result of their changed anatomy of their gastric system. And there are other medicines and other causes of increased alcohol consumption that physicians cause as well. But these are certainly very sad and important things to recognize. Certainly, possibly dietary toxins, maybe different neurochemicals like paint fumes may cause damage to the brain and increase drinking, psychiatric disease. It's also possible that infections or even antibiotic use can change the gut microbiome and select for microbiome elements that promote drinking. And of course, drinking is more prominent in psychiatric diseases sometimes. Alcohol's effect is complex, and it's known to produce endorphin stimulation as well as other neurotransmitters, dopamine, and so forth. And people get another important effect from alcohol, which is a reduction in pain and inflammation. Alcohol reduces the prevalence and the concentration of inflammatory cytokines. So, in other words, if you want to treat inflammation, if you've got flu or some other cause of illness, you drink whiskey and you feel better. It's one of the oldest medicines around, and it's because of its effect to make people feel better if they have inflammation. So let's just take a look at the big cause that we see today is the this inflammation that drives drinking. We'll talk a little bit about inflammation because it is so important to consider as the story on alcoholism. There's a number of things. I'm sure you all are aware these cause inflammation, and it's mostly, I think, through the effect in the gut and the microbiome and the permeability of the gut barrier causing what is commonly referred to as a leaky gut, where you get excess lipopolysaccharide debris from the dead bacteria, or also called endotoxin, that leaks out into the bloodstream in an excessive amount. And that can cause real problems. And it's increased by a change in the microbiome, a less diverse microbiome. And we can get that from antibiotics, from processed foods, food additives, a reduction in the amount of omega-3s, which can be a real prebiotic, or a substance which increases the diversity of the microbiome. These prebiotics can include, fibers and soluble fibers and non-digestible fibers as well. High fructose corn syrup could damage the gut lining, cause increased inflammation, as well as toxins and pesticides, glyphosate, antibiotics, and various drugs. All these things can impair the gut function, and as a result, we get excess endotoxin in the bloodstream. We get more brain inflammation through the signals given by the excess endotoxin. And the signals are these chemical messengers called cytokines, which are sort of like hormones, but they're given from cells to cells as well as in the circulation, and they cause us to feel sick. This would be why we get fever or fatigue, or why we feel withdrawn when we have an illness, why we have poor appetite. And all of these symptoms like irritability, anxiety, kind of brain fog or sadness, increased pain sensitivity, all these are really protective effects that the body mounts when we have an infection. These are protective things for the humans as we curl up in a cave and hide from other people, and we're more likely to fight off people that are potentially harmful to us, and we want to stay by ourselves. And of course, the fever may be protective as well in terms of helping our body fight off any infections. We feel tired, so we rest, and our body has a chance to heal. But these cytokines also make us feel lousy. And if we drink alcohol, it's less inflammation. We feel better. And that's one of the reasons why people drink. So I kind of put this together. This is the inflammatory cycle of alcohol consumption that I think is really underappreciated. And I know for number one here, excessive alcohol alters the gut microbiome. And we get this excesses amounts of bacterial debris or endotoxin into the circulation, which causes a inflammatory reaction in all the cells of the body, but particularly the liver. The liver responds by making more inflammatory cytokines to try to fight off this potential infection. And we get liver inflammation, we get liver fibrosis, and eventually liver cirrhosis. And all this, of course, is worse when the diet's crappy. High fructose corn syrup is extremely toxic to the liver. And that's probably why so few of my patients drink soft drinks, because if they did, they'd be far gone, and their brains wouldn't work well enough for them to come and get help. The liver, in any case, gives off excess cytokines, and the brain gets this inflammatory signal from the cytokines, and we have neuroinflammation. I didn't go into that too much in this talk because we have limited time, but what happens is the microglia, the white cells in the brain, are activated through these signals of endotoxin, as well as from cytokines that induce even more cytokines to be produced by the white cells in the brain. And the brain mounts this tremendous inflammatory response, which stops any new nerve growth. And it also causes symptoms like anxiety, depression. We get loss of control. Maybe I'm talking too fast. Any questions right here at this point?
So maybe I was curious about the high fructose corn syrup actually, and the link to
Right.
alcohol. Maybe we can talk about it later, but it sounds fascinating that that just there's an additive effect of alcohol and fructose, the corn syrup.
Absolutely, absolutely. So the worst thing you could do is drink whiskey and Coke. You know, it's not, it's really bad. And the new Coke with the high fructose corn syrup is a lot more dangerous, I think, than the old-fashioned Coca-Cola with sugar in it. So sometimes I'll just merely tell people, well, you're still going to drink your whiskey and Coke or rum and Coke, switch to the Taste of Mexico Coca-Cola, which has sugar in it, which is less toxic to the liver. And of course, one of the research projects I did was to find that there's a correlation between the amount of liver inflammation and the issue in the brain, the amount of neurotransmitter in the brain, and the amount of alcohol consumption. It's really all this is tied together, and I've got a link there to a paper that I wrote, just kind of describing the science behind all this. This is well worked out, even though it's not talked about very much. What's really not talked about very much is number 5, which is that when you get a hangover symptom or you just feel crappy from your brain fog, it's a motivation to drink. And you drink more and you're back to number 1. This is called the dark side of addiction. This is after people drink maybe initially to feel better and or to get a buzz, to have to experience a pleasure, but after a while they drink to prevent them from feeling worse. So it builds on itself. Everybody's seen these pictures of if you work in the emergency room long enough, you'll get to recognize people with alcohol use disorder by the fact that they have an atrophied brain for their age. Why would that be? Well, most people attribute that to heavy alcohol use. And we know that when people drink heavy, they lose brain volume, and it's particularly the white matter, the connecting fibers. And this shows these are both people age 40. And when you lose white matter, you lose the connections between the executive functions of the brain, the frontal cortex area, this willpower area, and you don't have as much control over your impulses. I studied domestic violence at NIH, and you don't have as much ability to control your emotions. You don't have as much ability to control your craving over alcohol, and you don't have as much insight because the different parts of the brain don't interact as well with each other. There's something called acquired sociopathy. This is where you have so much damage to your brain that you lose your good moral fiber and you become a sociopath, basically, and it's acquired. Mental illness becomes required. You have comorbid disorders. They all always attribute anxiety and alcoholism, or depression and alcoholism, or OCD. Everything is associated with alcoholism. And they just say, well, if you've got one mental illness, you've got another one. But I propose that it's because of the loss of brain volume. And the reason is because when you stop drinking, after they've done studies that show after about 6 weeks of no drinking, your brain volume increases by 2%. 2% increase in brain volume in just 6 weeks. And what grows back is the white matter. The white matter tracks are going back. So you start getting insight. So after you've been in your recovery program long enough, then you can pay attention to the group meetings. Then you can pay attention to the what people are saying, and you have some insight, and you may be able to break through the denial that's such an important part of this alcohol use disorder. All right, so how are we going to heal the brain? Well, let's think about that together. These are all the nutrients that have been shown in pretty consistent studies to be deficient in people with alcohol use disorder. The ones that have stars are the ones that have been shown in placebo-controlled trials to actually treat alcoholism or craving. And it's sort of an odd collection, but probiotics, Lactobacillus GG, or what's in yogurt, will actually allow someone to stay sober. It's a good research. It's pretty robust. Omega-3s, I talked about this years before we had the placebo-controlled double-blind studies, but it really does help people to stay off alcohol. And I see that clinically all the time. Also, mere calcium carbonate is 1 tum a day, helps people maintain sobriety. But all of these nutrients are probably critical. B vitamins, there's a lot of data from the era before we used placebo-controlled double-blind studies that shows that B vitamins really can help people not only recover mentally, but also actually reduce their craving for alcohol. I did a lot of vitamin D work. And it's hard to prove that these things reduce alcohol consumption, but we do know that they're depleted in alcoholism. And each of these has been used repeatedly with good effect. A lot of people talk about the MTHFR enzyme deficit in some people, and that can be really life-changing if you can identify the people that will benefit from the methylated forms of the B vitamins, particularly folate. So I was fortunate enough at NIH to be assigned a study that I really wanted to do, which was to look at the omega-3 fatty acid uptake into the brain, right? As NIH as a young scientist guy, I was gung-ho to do all kinds of nutritional stuff, and they weren't interested in that. But they did have this project that I was able to work on. And as we know, these are essential for the body. Omega-6 and omega-3 can't be interconverted. You only can get them from our diets. Omega-6 tends to be wildly excessive in our diets and also promotes more inflammation. Both of these are critical, but you can see they're almost identical molecules. The black arrow there shows the omega-3 has just one extra double bond, which has a critical effect to make the omega-3s more flexible molecules. And the metabolites of omega-3s are more liable to be put into different places in the body. They put in the same place that omega-6 is, but the omega-3s have a different flexibility, different functions, different abilities to, in effect, reduce inflammation. And it's really important to understand how critical it is to have less omega-6. So omega-6 is abundant in vegetable oil, soybean oil, corn oil, and all the animals that we feed corn, soy, and peanuts to, right? So what is that? That's chickens, that's beef, and that's hogs. And anybody that uses soybean oil in their salad dressing, they go, oh, I eat healthy, I have a salad. And the soybean oil is deadly for them. Omega-3 is really limited. We don't eat seafood very much anymore. Back in the couple hundred years ago, everybody in America ate lots of seafood, lots of fish, but not so much anymore. We do get omega-3s are a plant fat, so we get them a little bit in plants as the plants are growing, but they're not a storage form of fat like the omega-6. Omega-6 is a plant storage fat, and omega-3 is in the algae in the ocean as well. And that is where we get it from fish, because the fish eat the algae and it's concentrated in the fish bodies. Saturated fat is basically neutral. Um, if it's low in omega-6, like corn, uh, uh, like coconut oil, it's extremely healthy for us. Um, Grass-fed animals have grass-fed tissue. So they have more omega-3 in their tissue. That's healthy.
No,
Grass-fed
thanks.
lard, grass-fed butter. So I tell my patients that they really need to pay attention to these fats. This is why. All right. So omega-6 fat from soybean oil floods our diet. You can see that this has drastically increased over the last century or so. And Americans typically now have 25 pounds per person per year of the omega-6 fat in soybean oil. This is a huge increase. Before we were using lard, which didn't have as much omega-6. They just give you some really hardcore science and why this stuff is important. Here's a placebo-controlled double-blind study. So these people were studied at Harvard because they had severe bipolar disorder, and these patients were treated with the best medications we had in two groups, but one group had a placebo of, I think it was regular corn oil, and the other group had fish oil. And the fish oil group is the blue group. And these severe bipolar patients who got the placebo, they all relapsed and went back to the hospital. 60% of them had relapsed and had severe mental illness that put them back in the hospital by 3 months. However, only one or two of the group that took the fish oil relapsed. In the wisdom of modern industrial science, no one has ever bothered to reproduce this study, and it's pretty well been buried. But if you have somebody with mood swings, um, I suggest that you treat them with not just a pill of omega-3, but the dose that was used in the study, which is 9.5 grams a day. That works out to about 2 tablespoons of fish oil a day, which is just pretty reasonable if you remember that uh, fish oil, like cod liver oil, has been used for centuries, and people would swig it to reduce their arthritis. Omega-3 fish oil is only effective for arthritis, though, if you consume enough. If you have less than 5 grams, that's 5,000 milligrams a day for 3 months. If you have less than that dose, it doesn't work. I studied the brain, remember? So that was what I did. We had a group of alcohol disordered use disorder patients, and we compared them to normals, and we found that the omega-3 uptake in their brains was greatly increased in recovery. This told us very clearly that the alcohol patients needed more of the omega-3 in their brain. This is what their brain was missing when they were heavy drinkers. We also found that the half-life is 2.5 years. What that means is that it takes a long time to restore normal brain composition. You may get an effect right away, which I often do, but to really maximize the change in the brain, it may take 10 years of a normal diet to get where people should be in terms of the omega-3 versus omega-6 content in their brain. Again, so the healthy behaviors here, we want to have more omega-3s for our patients, increase vitamins and minerals, prebiotics, probiotics, fermented foods. I didn't mention exercise, but that can be critical to help the gut function. Organic food, of course. Zinc is really important for gut function. Also, I like to tell people this is where you really encourage your patients to drink coffee instead of soft drinks, because coffee can improve the gut function. One thing that I think is really fascinating is that increased omega-3 increases the short chain fatty acid production in the microbiome. So there are microbiome elements that increase the amount of butyrate, which is one of the three ketone bodies. And the butyrate from the microbiome elements signal the brain to create more brain-derived neurotrophic factor, or BDNF, and that increases brain growth. So instead of having inflammation causing reduction in new nerve growth, you have BDNF and this butyrate increasing brain growth, and sort of the yin yang of inflammation or butyrate that and BDNF that's acting on the brain. And if you've got brain growth, then you can get new ideas about drinking. You get new insights. Your brain works better. My patients routinely tell me their head feels clearer. This is one of the most sensitive ways that we can tell that our nutritional therapy is working. Patients think better and they understand that this is really something that's going on related to their diet improvements. All right, so now we want to talk medications. And I really don't have time to give you the full story here because there's so much to tell you about these medications. We have some wonderful things that I use routinely. Don't use disulfiram very often. That was what we used to use years ago that would make people sick, an aversive therapy if they drank too much. We have approved by the FDA acamprosate, which is a wonderful drug that helps people, particularly those who have committed to staying abstinent. You use the medicine 3 times a day, and it reduces kind of the unease, the anxiety that people say causes them to start drinking after they've been abstinent for a while. It's a pretty safe drug. I have noticed some people with some what did I have? I think leg swelling one time, but it's fairly safe and easy to take. It's related to a amino acid. And then we also have naltrexone. Naltrexone comes in a number of forms. It's very much like nalmefene, which is available in Europe. But naltrexone here in America can be obtained by an injection, which is supposed to last 4 weeks, and by also sometimes it's formulated in more long-lasting forms with a compounding pharmacy's help. But we also have some other medications that I think are really very fun to use. Ondansetron, Zofran, at a microdose is really my favorite drug. People can't imagine that this little pill they take for nausea for their kiddies. When I give them 5 drops of the pediatric liquid of ondansetron, it can be life-changing. It's amazing when it works. And it works for a certain number of people with a certain genetics. It doesn't work for everybody, but it particularly works for people with a family history of alcohol use disorder or early onset alcohol use disorder, symptoms of alcohol use disorder before age 25. It is remarkable. They use 5 drops of the pediatric liquid twice a day, and it changes their outlook. It's fascinating. It doesn't work in the same way that naltrexone works, but it makes people feel like they have more willpower. So they take it and they say, "Doc, I don't think the medicine works, but I quit drinking anyway." It's really quite astounding. Toprimate or Topamax has been around forever. We use it for weight loss, impulsive control disorders, as well as for seizures and migraines. But it also works great for alcoholism, probably more, or at least a strong effect on alcohol use disorder, but it does have more side effects. Baclofen, it's the same way, very effective, higher doses work. Long story about how that became useful. It's not as well accepted, and it also has a lot of side effects. And people can find that habit forming, so they want to take it, and sometimes you have to watch out for that. And the same reason I don't like to use gabapentin. Gabapentin it can really help people stop drinking, but they also become dependent upon it, and I don't use it for that reason. Varenicline also helps people stop smoking, but it can also be useful for alcohol use disorder. And also the blood pressure medicine prazosin, also called Minipress. Extremely fun to use this on somebody with high blood pressure. It can just cut their alcohol consumption way down. Less common, I've listed a whole bunch here. There are wonderful cures for some people reported from all these kinds of things. I'm particularly interested in neuroelectric stimulation. One day we'll have that. I hope they'll approve that for alcohol use disorder because it's simple. It's very little side effects, inexpensive, um, fabulous. Other things, I'm not a fan of the hallucinogens for a lot of reasons, but I'm also not a fan of GLP-1 receptor drugs. I just think there's too many side effects. So much stuff that we have that's fairly safe that gets people off of alcohol without resorting to some of these more dangerous things. My favorite one of these experimental drugs is the fecal transplant. So you probably are going to be able to get people off of alcohol and help them recover from the alcohol use disorder by a fecal transplant. So that's really fun to think about and how the microbiome is really promoting drinking. Just graphs to show that all these medications work to reduce craving, and they reduce it over time. It's not instantaneous. Repeated use allows the brain to change its function. Here's just a list of the medications and the doses, so you have them on your slides. But let's talk about naltrexone. This is what we wanted to talk about, especially today. And naltrexone blocks the euphoric effect, the buzz from alcohol caused by opiates. Alcohol use disorder is driven by this euphoric effect, particularly in people with genetic predisposition. It's not an opioid. Can't get addicted to it. It's highly specific for the opiate receptor, and that makes it safe. Side effects, mostly headache, nausea, anxiety, dizziness, depression. But over time, people can experience a feeling of blah. There's less excitement about life. And so if you take this drug for a long period of time, day in and day out, every day, you just get tired of taking it and you quit. And oftentimes people relapse to drinking in that case. Typical dose is one pill or 50 milligrams. You can also start with smaller doses and work your way up. That's particularly important if somebody's a heavy drinker. You want to start small and work your way up, and you'll have less of the side effects. By the FDA label, people use it once a day to promote abstinence, but actually it may not be enough naltrexone blood level to be effective. The higher the blood level, the more likely people are to experience a beneficial effect. What's also interesting is you can imagine that if you have a drug that you're using day in and day out, it's going to affect the brain. And what happens is the opioid receptors become dulled by this blockade. And when the naltrexone is removed, the receptors are looking for more stimulation. They have become oversensitized. And so when someone drinks after a prolonged use of naltrexone, that alcohol drink can be even more rewarding than usual and create a lot more desire to drink and a really severe relapse. Injectable naltrexone, this Vivitrol, is very helpful sometimes. As you know, we use it for opiate addiction. After about 3 weeks, you may need to start using supplemental pills to make sure the blood level is high enough. Again, different people have different blood levels, which makes it important to pay attention. But for the right people, alcohol use disorder can be remarkably affected by ondansetron. One patient wrote, they feel like they've been released from prison once they get this in their body. For some people, it can be a life-changing experience. No longer do they feel guilty about craving alcohol because they realize it's some chemical thing in their brain, and they're able to move on. And we'll hear more about using that to good effect as we go on here. And we think about David Sinclair's work with animals, and he's the one that came up with the Sinclair method. But he started out using animals that were trained to drink alcohol. And what he found out was that the longer the alcohol consuming animals were deprived of alcohol, the more they lever pressed to get it, the more they wanted it. And they found that the abstinence from alcohol would actually upregulate these endorphin receptors and promote excessive drinking. And Sinclair thought that this alcohol deprivation effect basically explained binge drinking. And that's sort of in practice what happens. But what Sinclair found out is that he then said, okay, well, if it's the endorphin receptors, let's block it with naltrexone and see what happens. And he found that this would completely extinguish the rats' interest in pressing the lever. They would extinguish their drinking behavior if alcohol was always preceded by naltrexone. So this led him to postulate that you could use naltrexone before drinking to rewire the brain and eliminate alcoholism. And so Sinclair tried this, and he found that when people took naltrexone religiously every time before drinking, after about 3, 4, 5, 6 months, a year, they would just lose interest in drinking. They would start out wanting to drink less, perhaps, but by the end of the time, they just had no interest in drinking anymore. Um, One thing that Sinclair recognized was that on days when people weren't drinking and they didn't plan on using the naltrexone, um, their because their opioid receptors would be upregulated, it would really help the process if they did other fun things that would increase endorphins during that time. And so these alcohol-free days, the non-alcohol pleasurable activities would be reinforced and they would replace the desire to drink. And Sinclair called this process pharmacological extinction, thinking about the extinguished behaviors of the animals. What I want to show this slide here, this shows that the two ways of using alcohol have very different effects. Okay, in the first way here, patients were treated with dignity. They were encouraged to just cope with drinking. The physicians and counselors recognized that the patients had an abnormal drive to drink. If they failed and overcame, if the craving overcame their willpower and they drank, they just were encouraged to keep trying, to keep taking the medicine, but try to drink less. Do the best you can. We know it's hard. In that group, you can see the naltrexone had a remarkable effect to reduce the amount of heavy drinking. Okay. In the second group, and again, this is placebo-controlled studies. These were, I'm not going to go into the details of it, but in the second group here, the patients were told, take the naltrexone every day, stop all drinking. You must be abstinent. You have to stop drinking. And in that case, the naltrexone patients did worse than the placebo. Okay, so what we tell our patients is critical. We must be compassionate. We must understand this is a brain disorder. We must understand how the naltrexone works. It works on the endorphins that are produced by alcohol consumption, and it also works on the thoughts that are produced when someone thinks about drinking. So that's why naltrexone can work not only when people drink, but when they're just thinking about drinking. Well, this is where I put Sinclair's idea together with what we know about pharmacokinetics of naltrexone. So you can see in this graph here at the pharmacokinetic profile show that if you take naltrexone an hour after that, your blood levels are the highest, and that's when it's relatively effective in the brain, blocking the effect of the alcohol. Somebody takes a drink at time 0, it's not going to work, but after an hour, they take a drink, the naltrexone is going to block the effect of the alcohol, and there's not going to be as much pressure to drink. There's no reinforcement to drink. And that'll last for 4 hours, maybe 5 or 6, maybe 8 hours, maybe only 3 hours, depending on the genetics. But in general, if you take the pill an hour before, it will block the effect of the endorphins produced by alcohol, and people will lose interest in drinking. And over time, if they do this over and over and over again, there's no reinforcement to drinking, and they'll lose their interest, and they can decide to be abstinent or even just take it before they drink and prevent themselves from binging and drinking excessively. This just shows that in Sinclair's work, if patients took the medicine, if they comply with therapy, the amount of alcohol craving reduced, but it reduced over time. It wasn't instantaneous, but it did drop rapidly, but over time, it really increased the reduction in drinking. This graph here is kind of complicated. The purple is the drinking. The red arrows show when naltrexone is taken, and you can see in the first case, people would be drinking, they go into detox, and they're told to take naltrexone every day. And they would drink, it would work a little bit, but after a few months, they'd quit taking the naltrexone, they start drinking again, and they'd relapse. And the second condition, which is what Sinclair recommended, is that you start taking the naltrexone while you're still drinking, and it reduces the pleasure of drinking. You drink less and less over time, Every time they drink, they take a pill, they don't drink as much, and over time they just lose interest in drinking. And this is definitely harm reduction of alcohol use disorder. This is really helped when people take a real interest in their own treatment. One of my colleagues says people need to pay for their treatment, they need to track their drinks, they need to take the pill, and that's what works. And so shows how people can track it on this graph that was created by an app from the C3 Foundation, which is this foundation started by Claudia Christian that helps people become aware of the use of the Sinclair method to reduce drinking. Sinclair method is also called just the targeted use of naltrexone. And there's a lot of data on this. Some of my slides will have some of the references for that. But you can see in this patient here, the patient was drinking the equivalent of 2 bottles of wine a night. First week or so, they drastically reduced their consumption to less than a bottle of wine a night. Dramatic. A few weeks later, up again, back down again. And at this point right here, oh my gosh, they've been 2 months in. They've been taking the medicine. They're drinking more than ever. What do we do? Is it failure? And fortunately, these people had a coach. A lot of this success is dependent on having the right kind of social support that are going to encourage people to keep taking the medicine, be patient. The medicine's going to work. And so, as you can see, this patient kept taking the medicine, and a few weeks later, they're back down to where they were with 1 bottle a night, and then just a month later, they're down to 0. All right, so this is typical for some people. Some people have a gradual reduction over time, and some people have this up and down. But if people keep taking the medicine, eventually here they drank occasionally, but here they just stop drinking. This is over, I think this is 52 weeks. So you can see that this is one of the pathways that people take. Sometimes it's different. Possible benefits of the Sinclair method are that you can permanently eliminate alcohol craving. People who reject abstinence, they don't want to quit for good. They can be engaged to treat. Less need for inpatient detox. It's cheaper, fewer side effects than when you take the medicine every day. It's very inexpensive. Possible harms. So we have to consider what damage we could do. Well, somebody may be too severe alcohol use patient to benefit. They may not benefit because they don't get the benefit of the social support of the 12 steps and the personal growth that people could get through following these 12-step principles. Naltrexone may give false confidence that they don't need to be involved in any life-changing activities. And sometimes non-compliance will increase consumption. It can further, of course, people can still drive drunk while they're taking the medicine. Why does it fail? Sometimes naltrexone doesn't work based on their genetics. Sometimes people drink too fast, or they'll drink a stiff drink. They'll, instead of drinking a glass of wine or beer slowly, they'll guzzle a whiskey. And the whiskey or any concentrated spirits can overcome the effect of the naltrexone. Sometimes people just don't have a recovery program. They don't have the spiritual or psychological support that they need for recovery. Sometimes people are just suffering too much. There may be too much pressure. They may be bored. And all these things can interfere with the success. And I have many patients who sadly, even though they completely abstain from alcohol for a year or more because the naltrexone worked and they reduced their desire to drink, something bad happens or something good happens, and they say, "Oh, I must be cured by now, and I'm not going to a group, and I'm fine. I don't have a problem." They start drinking again. The second time around, it seems like the naltrexone might be harder to get going. It might not work as well. All right, so this just really briefly says Bruce Alexander did a study called Rat Park, and basically animals that were addicted to opioids had less addiction once they got to play with other rats. They just lost their addiction to opioids. These are all the things that create endorphins that we know of. So this is what we try to encourage our patients to do to replace the endorphins from alcohol. This slide just shows that the 12-step groups are critical for some people to stop drinking. In this meta-analysis of 27 studies, only one study showed that something was superior to Alcoholics Anonymous. These are good programs, and they're sometimes there's a problem with the Sinclair method because the program doesn't allow for the use of medications in the way that we use naltrexone. But these are important to understand. So get back to my patient, John. I told him to eat a great diet, exercise, get a support group where his shame could be diffused by people who understood him and could empathize with him. Encouraged him to track his drinks, to switch from whiskey to drinking beer slowly, and to use naltrexone to extinguish the craving. His effects were typical. The omega-3s and vitamins rapidly increased his ability to think clearly. He just felt better. Consistent use of naltrexone drastically cut his craving. As he said, naltrexone gave him an off switch. Fortunately, he became more involved in his religious activities, and he changed his counselor to find a counselor that was able to help him with activities that he needed to do and not activities related to drinking. Now he drinks occasionally, but only after taking the pill. All right, so now we are blessed to have a friend and colleague of mine, Katie Lane. And Katie found out about the Sinclair method about the same time I did. And she has a personal story that she will share with us now if we could let her help answer some questions. Katie, why don't you tell us about your experience with naltrexone? I think we have a few minutes left in our presentation here.
Yeah, nice to meet you all. So just really briefly, I struggled with alcohol for nearly, did you want to stop sharing your screen, John, real quick, maybe?
Yes. Yeah.
But I struggled with alcohol for nearly 10 years, and I was a daily binge drinker, and I tried countless times to quit drinking over the years, and I could always make it a couple weeks, couple months, but eventually I would return to drinking again. What I now know is likely due to the alcohol deprivation effect or just the craving I had for alcohol. So even though I sincerely wanted to address this issue, I just couldn't stay sober. It was like the desire to drink was beyond my logic and reason and control that I would ultimately just give into it. But in 2017, I learned about the Sinclair method treatment, targeted naltrexone 1 hour before drinking, and it sounded too good to be true. But I knew I had to try it. And I started on the treatment around July of 2017, and my goal was to be a moderate drinker. I learned that this treatment didn't require abstinence, and even though I liked the idea of being able to be abstinent, the thought of it terrified me, and it seemed impossible because I'd tried so many times before. So the concept of like, hey, I can start a treatment that's going to help me drink less, that was very appealing and doable and just gentle. Like I wanted to fix my drinking, but abstinence seemed really difficult. So my goal starting the treatment was to cut back and to be a more of a moderate social drinker. And the treatment did that for me. Within about 8 months of the protocol, I went from a daily binge drinker, 1 to 2 bottles of wine a day, plus binge drinking all weekend, like all day long, to someone who after about 8 months, I was literally having like a glass of wine at dinner once or twice a month. It was pretty incredible to see that transformation and just see that I didn't desire alcohol anymore. Like I just didn't really care about drinking. And after about a year of this protocol, ended up going, I tell people I'm accidentally alcohol free because I never intended to just quit drinking or say I'm never going to drink again. But what happened was after a year, I just truly lost interest in alcohol and went 4 months without drinking. And after 4 months of realizing I didn't care about alcohol anymore, I decided I was going to stop drinking. And that was about 6 years ago now. And I feel still like the results are permanent. I don't take naltrexone anymore. I don't crave alcohol anymore. I don't desire it. I feel completely free. Like my brain was taken back to the place it was in, you know, in my teenage years before I ever had alcohol use disorder. So that's my story with naltrexone and the Sinclair method. And I will say that nutrition came in for me kind of after TSM, when I realized I wasn't feeling as good as I thought as I would be by, you know, reducing my drinking. And that's where I personally kind of was self-taught around, like, you know, important nutritional things. John's been a huge mentor to me in that regard with fish oil and things like that. But yeah, this treatment was life-changing for me.
So I use Katie's program called the Thrive program all the time for my patients because I know that they need more than what I can offer in my brief visits. So she has a program where she coaches people to just encourage them to keep up with it because it's really hard for people to remember to take the pill day in and day out for a year if they need to. So that's something Katie's become really quite proficient at, and you can ask her about how that could work for you guys too. So any questions about anything? We really wanted you to have the opportunity to ask some questions. I only have a few minutes left in the hour, but
Hi, thanks so much for this.
sure.
And Katie also, I'm sure it was naltrexone that a very good friend of mine who struggled like I am myself this month, 18 years in a row, clean and sober in a row. And the naltrexone, a very good friend of mine who also struggled for years, we would get in touch off and on, you know, always like every few months. And this was back in 2016. And he said, they put me on this thing and I went to the bar and I had 2 drinks and I didn't want any more. And he was so excited. And I was skeptical, but I was like, oh, interesting. And he actually died later that year alone on the funky houseboat he was living on. But what I think that whoever he was doing it through, I don't remember if it was Kaiser or I don't know, that it wasn't probably comprehensive with the other nutrients and things like that. He was a brilliant guy too. It was crazy. And for myself, I struggled after it was becoming clear that it was becoming a problem, but I didn't understand it because it didn't used to be a problem for almost 10 years until 2006, until I found out, I didn't even know about the amino acids really then, but that damn fish oil was, I think it was absolutely a game changer. I really, really do. And anyways, that's my personal experience. And this has been really interesting. And the other thing, of course, is that for anybody out there who has the problem with alcohol, fentanyl, all that stuff, if they have insurance, even the insurance doesn't cover nutrients. It only covers pharmaceuticals. So anyways, that's it for me. But thank you. This was great. Thanks.
What's the dose, John? What's the dose of omega-3s that you find to be effective in your population? I know you said very high doses for bipolar, like 10 grams. What do you think is an effective dose for an AUD?
Well, that's the only study that we have to guide dosage. You know, okay, so I always recommend 10 grams, 9.5 grams, because I use that study as my guideline. I will say I had one fella that came to me who'd been on naltrexone and a couple other medicines combined for treating his alcohol use disorder for a number, maybe 3 years or so. And he was drinking like vodka every day. And I said, okay, well, you're taking all these medicines. What do you take for fish oil or nutrients? He says, well, I don't do anything. I could take this fish oil at this dose. And 2 weeks later, he came back and he said, Doc, I didn't follow your advice. I took double the dose of fish oil. And I also quit drinking. I don't drink it anymore. Thank you very much. And I've never seen him again. So,
So you do 20 grams a day? Like he
20
was
grams.
much
Yeah.
wealthy.
Yeah. The side effect you get it above 23 grams is you get diarrhea, right? So whatever. But that it's food, right? You digest it as food. You could do the same, the 10 grams. You could do that by eating a nice piece of salmon three times a day.
Yeah, that's amazing though. 10 grams is pretty good dose. And how soon do you see individuals respond with that high dose? I know you
Overnight,
know, sorry,
overnight.
overnight.
Yep.
Huh.
Overnight. Sometimes. I mean, not all the times, but basically, wow. The first time I came back from an omega-3 conference over in, I forget where I was, some conference I was sent to about it was the ISFAL, International Society of Fatty Acids. They were passing out samples, right? So I brought it home and said, I'll try this stuff. I took some fish oil. I said the dose was teaspoon. I said, I'll take a couple of tablespoons. So I took a couple of swigs. I couldn't go to sleep. My brain was so active. I was laying there thinking and just having wonderful thoughts, laying in bed for hours and hours. But this stuff can cause mania if you have too much EPA. So you have to be careful if somebody has that's the only side effect I've ever heard about. And I've had 2 cases where I've heard I've heard through the grapevine they can cause mania.
Yeah, but yet in the bipolar patient, you're giving them 10 grams, right? Because the bipolar
Right.
base.
But that was if you have the higher, okay, there's several kinds of fish oil. Well, there's all kinds, but DHA is a 24 carbon that's in cod liver oil. That probably does not cause mania. That's what I recommend. But the high EPA, which is from menhaden fish, may cause more mania. Yeah,
Okay, so more of the DHA and less of the EPA is better for the
yeah.
brain. Okay. No, that's amazing. Yeah, I don't know that I've ever pushed fish oil that high. Usually
Try
maybe
it.
4 or 5
Try
grams.
it.
My top is, so I'm going to try this higher dose,
No,
but more.
if you look at the arthritis literature, I did a review of that, and if you're below 5 grams, it doesn't work. It just
Is that
doesn't.
also again, when you say, but it's not, is it again EPA versus DHA? Like, is it more
Well,
concentrated?
that's those studies were a compilation of all the studies that had ever been done for treating arthritis. It's like a meta-analysis, and for the dosage to be effective, it had to be for 3 months at 5 grams. So
It doesn't matter which one, right? EPA versus DHA.
probably not. There's no data, unfortunately.
No, I'm
I
going to try.
definitely was not doing it that high here because
Pardon?
I know about it, but it's still, I believe with all my heart, made a difference.
Oh man, yeah, it's the most fun
Crazy.
thing to
Yeah.
tell people about. It's just crazy.
Well, thanks.
I've seen it, I've
Extreme.
seen it, I've seen it, I've seen it work for night terrors for little 3-year-old children, right? So they have night terrors and they the next day, they come up to their mommy and say, "Mommy, I'm so happy," and they quit being whiny, they quit being combative, they quit having a temper tantrums. They're a different child from then on.
Just high dose DHA.
Just
Just
like
give it
that. Just
high dose DHA.
two tablespoons of cod liver oil twice a day.
Oh, sorry, 2 tablespoons. How much?
2 tablespoons of cod liver oil twice a day, which works out about it's close to 9 grams, something like that.
Wow.
But cod
But
liver
this
oil
is for a 3-year-old. This was for a 3-year-old. I mean, they're little kids, so
yeah, cod liver oil has much more, right? It has vitamin A, maybe even vitamin E. It
yeah,
has
yeah, something like that. There's a big
great.
controversy. There's some. John Cannell had this idea that it was too much vitamin A in cod liver oil, and he got Willett and all these guys to do a study about it, a paper about it. It was hogwash. It's just hogwash. Vitamin A is okay. The doses in cod liver oil. It's just, I mean, we've used it for centuries, and so it's safe, right? How much more clinical experience do we need, right?
Amazing. Anyone else have questions, comments? Bruce, Heather?
No, I just find it fascinating because on Saturday I'll turn this medallion in for a 42-year medallion, and
Oh wow!
and I came across
Congratulations.
aminos in probably 30 years ago, and I regularly attend both ACA and AA and support my colleagues. And as I told Valsa, I just got back this weekend from a week-long Zen session in the Catskill Mountains at a Zen monastery. And so I'm a big advocate of absolutely everything you've said, and harm reduction, and you know, obliterating shaming, and horses have been a great reward in working with military vets and first responders, and alcohol sobriety live-in groups as well as mental health groups. And so, you know, it's not one and done. It's very holistic, and I appreciate your presentation, and I hope we have access to it and can find you further if we need to, as well as the other young lady that just left.
Yeah, we have the contact information in the chat. We have Dr. Umhau's. I don't have Katie Lane's, but I have Dr. Umhau's, and you can get in touch with Katie through Dr. Umhau.
Thanks.
Her program is called the Thrive Alcoholism Recovery. So that's what she does. It's a really neat program. Again, it's you know, I use all these other medications in a targeted fashion as well, right? So the problem with taking Topamax for drinking is not that it doesn't work; it's that there's side effects. So I had a patient who was taking Topamax um, for weight loss, and I had seen her because naltrexone didn't work. She was one of the 20% of the people it didn't work for. And so I said, well, doesn't the Topamax help your drinking? He said, well, no, not really. I said, when are you taking it? Well, I'm taking 100 milligrams at night before I go to bed, 100 milligrams before I go to work. And they said, when do you drink? I drink at happy hour, right? So there's no blood level of Topamax. And I said, okay, quit taking the 200 milligrams, take 25 milligrams, but take it an hour before you drink. And she eventually went up to 50 milligrams, but she quit drinking on that medication timed to treat her symptoms.
So do you always now give naltrexone with the Sinclair protocol or the targeted approach versus doing it around the clock, like the conventional recommendations?
I don't give, if somebody's drinking around the clock, then I'll do it that way. You know, if somebody's drinking 24/7, you have to, that may be different. They may need to go into rehab, but generally people are drinking in the evening. And so I just target it right before they drink. And then if they get to the point where they're able, if they do that long enough, they'll have a few days a week where they're not drinking, and they don't have to take it then. People are going to do what they're going to do anyway. So you say, listen, you know, my advice is stop drinking, but I know you can't. That's why you're seeing me. So here, let's work with your situation. And so I think, okay, if you're going to drink, at least take the medicine an hour beforehand. And you know, they're going to figure out what works for them. And I just tell them you have to be religious about taking it every time you drink. Sometimes they'll take it beforehand. So my heart goes out to all these guys who white knuckle it for decades in AA, right? So for those folks, what they could do to prevent them from drinking or from having this craving. Okay, remember Pavlov's dog? The dog started to have the salivation when they just heard the bell. So the neurochemicals were going on when they heard the bell. So when somebody walks into a bar, even though they don't intend to drink, those endorphins are being released. So if you've taken a naltrexone beforehand, you block the effect of the endorphins, and you're not craving alcohol. And so you do that over and over again, even though you're never going to drink again, and eventually you lose the craving. I think that's what it worked for.
So thank you so much. So members of the Alliance will have access to the recordings. So please join the Alliance if you can, support us. And so thank you so much, John, for being here, and really appreciate your presentation. It was awesome. It was really good. Very informative.
You're very welcome.
Come back and teach us other things from your past.
You guys have to teach me about aminos sometime. So
yeah, that would be great, actually. Yeah, that's our focus is looking at neurotransmitter imbalances and using targeted amino acids to sort of boost up these different neurotransmitters. So yes, we welcome you, and we would love for you to be part of the group.
Thanks very much.
Yeah, and a reminder for the next couple of sessions, please join us for neurotransmitter testing. That's in August, and next month is inpatient addiction treatment, holistic addiction treatment. All right,
Have a
guys. Thank you so much,
have a great
John.
week.
You're welcome.
Thanks again.